Okay, thank you very much, Professor Naguib. أولاً, I like to thank the organizers, especially my very dear friend, Dr. Amal al-Bishlawi and Dr. Aza, for inviting me to lead the session today. ولو إني بشفق على الناس إنها تبتدي اليوم ب congenital platelet defects, because a congenital platelet defects it's very complicated and it's not easy to comprehend, but I promise I'll make it very simple for you. And the most important is that when we suspect a case of congenital platelet defect, always the physician expect that the lab will answer his question. Is this congenital platelet defect, and what type of platelet defect? And on the other hand, the lab doctor expect the physician to know better than this. I want to tell you that to diagnose a platelet defect, there has to be a combination effort between the physician and the lab in order to reach a diagnosis. Before I speak about platelet defect, I'll refresh your memories about the role of platelets in hemostasis. We all know that the principal function of platelet is physical plugging of damaged tissue, initiation of a coagulation process, release of vasoactive substance, and it is the basis for fibrin clot formation. So platelet is really very important. This is a very simple schematic presentation of a platelet morphology. It's very important to know that there are granules in the cytoplasm, and the most important is the dense and alpha granules, which when activated, they secrete a lot of substances that helps in aggregation, in adhesion, and in promoting the function of the platelets. Platelets, as we all know, they are formed from megakaryocytes in the bone marrow. They stay in the bone marrow for 4 days. Then they are released in the circulation. They live in the circulation for 8 to 10 days. And we all know that 80% is found in the bloodstream and 20% is stored in the spleen. Platelet, when activated, they acquire this shape with many pseudopods in order to increase the surface area. And at the same time, it exposes a lot of receptors that initiates the release of the main aggregating agents, that's the ATP and the thromboxane A2. The receptors involved on the platelets are the 2B3A that is responsible for fibrinogen and von Willebrand, the 1B9, that's the von Willebrand, 1A, 2A for collagen, and 5 for thrombin. This is how the platelets expose the receptors, and at the same time the receptor is attached to other element into the collagen to help in adhesion, and this is how the platelets perform aggregation through this receptor, through fibrinogen and through von Willebrand factor. So we can understand the importance of these receptors for the function of the platelets. The first thing that the physician faces when a patient comes with a platelet defect, a question rises into his head. Does the patient have a platelet-related bleeding disorder or not? In order to answer this question, the physician has to perform a lot of history. If you tell me what is the most important investigation for any bleeding disorder, is taking a very good history. By the history and the physical examination, we can assume that the kind of bleeding is mucocutaneous bleeding and that the platelets are involved in this. Also, of course, we all know some features very characteristic of platelet disorder, as the site of the bleeding, the fact that it is spontaneous, it is full of petechiae, and ecchymosis is always small, superficial, and the hemoarthrosis is rare, and all these characters differentiated from the coagulation platelet disorder. So the first question, is this a mucocutaneous bleeding or not? By fulfilling this, we can assume it is a mucocutaneous bleeding. Although our understanding of the mechanism of platelet dysfunction and thrombocytopenia have improved significantly, the tests and skills required to recognize individuals with platelet-specific bleeding disorder have essentially remained unchanged. So don't expect a lot from the lab, because we don't have the means to diagnose all these diseases. In order, we now confirm that the patient has a mucocutaneous bleeding. So what are the tests to be performed on this patient? We have to do a full blood count with examination of the peripheral smear, and I will go through that in details. We have to do PT and PTT just to exclude coagulation problems. We have to do von Willebrand antigen, von Willebrand resuscitin cofactor, and calculate the ratio, because von Willebrand disease is, after all, involves platelet, and it gives a presentation as mucocutaneous. So I have to differentiate between the platelet defect and the von Willebrand. Then we do the bleeding time, clot retraction, PFA 100, and sometimes we resort to flow cytometry. All these tests have limitation. They can help, but they won't lead us till the end of the diagnosis. I have to speak about bleeding time because a lot of physicians put a lot of hope on the bleeding time. We all know that the bleeding time is performed by 3 methods: the IV, the template, and the tube. The IV method is the best method. In Egypt, we don't perform the IV exactly as it should, because we may apply a cuff and we may raise the blood pressure to 40, but we always use a needle. We never in Egypt use a lancet. It is supposed to use a lancet with a certain length and a certain depth in order to standardize the puncture in evaluation of the bleeding time. We don't do that. So difficulties in bleeding time, it is strongly user dependent. في ناس ايدها قوية كده وفي ناس تعمل بخفية. Very difficult to standardize. Time dependent. When it is cold, there is vasoconstriction. When it is warm, you can get blood easily. Result may depend on vascularization of a specific area of the skin, and applying a venous cuff may already affect the platelet function and fibrinolysis. By using the lancet, it is invasive and scar remains afterwards. The American Society of Pathologists stated that the preoperative bleeding time test lacks clinical benefit, and it is not needed as a preoperative measure. So you will ask, what can we do to any patient ongoing operation? The best thing is to take a very good history of bleeding. Other test for platelet is a clot retraction. It's a very rough test, but it is sometimes used. And because it is rough, it's becoming automated now in some centers, but again, it is not used in Egypt. We come to something, it's written always in the literature, and I've been asked a lot about the PFA 100. PFA 100 uses whole blood through a capillary device to mimic the high shear stress condition that occurs in vivo. It exactly stimulates primary hemostasis. This is the PFA 100. It has a carousel and two cartridges, one with adrenaline and the other with collagen, ADP, sorry, and the other is collagen and epinephrine. There is a capillary, blood passes here, and it meets the ATP or the collagen, so it causes a clot, and the flow of blood stops, so we call it closure time. Here it shows better. Here is blood going through this tube. It comes here and it forms a clot, so the flow stops and closure time is calculated. It's a very simple test. Recently, the initial enthusiasm for the PFA 100 as a screening device has diminished because of the device reported low sensitivity in individuals with a mild platelet secretion defect or storage pool disorder. So there is a big problem now. I said every test of these has fallacies. So how are we going to diagnose the congenital platelet disorder? No, there is still a hope. The first thing, that's the problem of the physician again. He has, or they have to decide, is this defect in the platelet acquired or congenital? So the first question is it a mucocutaneous? Is it a platelet defect? The second is it acquired or congenital? We all know causes of acquired thrombocytopenia, and by taking full history, we can go through all this to be excluded. And at the same time, there is a lot of conditions that helps the physician to decide that this is a congenital disease. Persistence of neonatal thrombocytopenia, family history, presence of associated clinical or laboratory feature. This is a very important feature to diagnose or to suspect the presence of congenital platelet defect. This is a clinical and laboratory feature associated with congenital platelet defect. So this is the problem of the physician, that they have to see all these clinical manifestations. Is it present or not? And every one of them helps to decide what type of disease. It helps, but the lab will help him more later. But as a start, they have to go through all these signs. As a first step in the assessment, two values in the complete blood count should be carefully reviewed, since they can provide critical information in the differential diagnosis. Platelet count and mean platelet volume. You see, the solution is very simple. All these tests have fallacies, but by careful evaluation of the platelet count and the mean platelet volume, which is ignored by many hematologists, really are the keys to diagnose the congenital platelet defect. Several platelet-related bleeding disorders are associated with thrombocytopenia, whereas in others, platelet count and morphology are normal. So we are going to be sure that it is a mucocutaneous, it's a platelet defect, and by history we know it is congenital. We'll see the blood picture. I have two possibilities. Many of the congenital thrombocytopenia can also be characterized by platelet size. The normal MPV is from 7 to 11. Platelets smaller or larger than this, as well as giant platelets, are unique to particular congenital thrombocytopenias. These two features will help a lot, as we will see later. There is always a question, what is a large platelet and what is a giant platelet? They agreed that large platelet is the size of a lymphocyte and a giant platelet is the size of a neutrophil, which is really giant. Again, important of the blood picture that I have to look at all the blood smear, not only the platelet. One of the important cells I have to look for is the neutrophil population, because many of the congenital platelet defects have also abnormalities in the neutrophil. The most important is the Shinya-Higashi and the dual bodies that can be found in these patients. So the possibilities when I do a blood count is one of two. Either I get a normal platelet count or I get a thrombocytopenia. If I get a normal platelet count, we'll see how we'll manage. If I get a thrombocytopenia, I have to look at the MPV, because I'll divide the disorder into thrombocytopenia with a low MPV, thrombocytopenia with high MPV, and thrombocytopenia with a normal MPV. Let's talk about normal platelet count, congenital platelet disorder with a normal platelet count. What can we do in this case? The direct question is, I do platelet aggregation. Findings of platelet aggregation, either I find a disorder or I find normal platelet aggregation. I mean, it's one of two. Disorder with a normal platelet count and abnormal aggregation. What are they? They are all these defects. The Glanzmann, receptor defect, Herminsky, whatever. All these syndromes, I won't go through it because they are really very complicated. Maybe the pediatric physicians can help us in that. But all these share in that they are a congenital platelet defect with a normal platelet count, but give abnormal aggregation. This is an example of Glanzmann thrombocytopenia, is that this receptor is missing. So simply the platelet cannot adhere and aggregate to each other. So it's a very simple explanation for the disorder. Storage pool disease, there is a defect, so the delta granules are not excreted, and ADP and epinephrine are not secreted, so no adhesion and aggregation. Such test to the clinical pathologist, that's the aggregation, is, we do it, you all know, by using plasma-rich and platelet-rich and platelet-poor plasma, and we put an agonist, different agonists, and we measure the aggregation with these agonists. I'll go quickly. And we find two phases of aggregation, a primary aggregation and a secondary aggregation. The problem that we always face from the physician is that they always tell us why we don't see the two aggregation. We always see in your reports one aggregation. You only see one aggregation because these aggregating agents are very expensive. And when you say do aggregation with ATP or collagen or whatever, we use only one concentration, that's the high concentration. If we use the small or the intermediate, you can see the double or biphasic phase of aggregation. The problem is with platelet aggregation that you seldom ask for the whole panel. Usually you ask for ADP, collagen, and restocetin. But there is thromboxane, there is epinephrine. I mean, you have to fulfill all the panel in order to know exactly what is the defect. This is the aggregation, and this is التباديل والتوافيق اللي ممكن نشوفها. We can see after performing platelet aggregation using all these aggregation agents. You'll see some get normal, some get impaired, So at the end, we will know what type of platelet defect the patient has. Okay, that looks simple, but platelet aggregation test is one of the very tedious tests. Pre-analytical phase in the blood sample and processing is very common. You need to do platelet-rich and platelet-poor, and you have to fix your centrifuge on a certain velocity for a certain time. This is not achieved in every lab. Platelet count has to be over 100, and by this process it has to be over 200,000 to do aggregation. It requires very skilled technician. Principle is not very physiologic because there is no shear stress. It's difficult or impossible in thrombocytopenia, difficult or impossible in lipemic sample. Reagents are not standardized. There is no control, laborious, expensive. And of course, any drugs taken like aspirin or non-steroidal anti-inflammatory can affect platelet aggregation. Okay, I have a platelet. I am suspecting platelet defect, normal platelet count, and a normal aggregation. So what is the solution? This is a Scott syndrome by exclusion. Okay? Now, we come to what if the patient has thrombocytopenia? So we finish this, normal platelet count, we do aggregation. Abnormal aggregation, we saw the table. Normal aggregation, it is Scott syndrome. So we come to the group of thrombocytopenia. Disorder with thrombocytopenia and small platelet. It is Wiskott-Aldrich syndrome or X-linked thrombocytopenia. Another disorder with thrombocytopenia and normal platelet size. All these are causing the thrombocytopenia with normal platelet size. Disorder with thrombocytopenia and large platelet size. I want to show you how large it is. This is a Bernard-Soulier, which is atypical large. And this is Wiskott-Aldrich. You see the difference in size between this and that. And the list of thrombocytopenia with large platelet size. Now you're going to tell me, okay, you diagnosed, but we didn't reach to a specific diagnosis of everyone. This will never be attained except by correlating this with the clinical presentation. The only way, this is again large platelets. This is Bernard-Soulier, deficiency of adhesion due to impairment of this receptor. The only way to know the exact platelet defect is through very sophisticated tests like immunoaggregometry, electron microscopy, and gene sequencing. But at the end of the day, the management of all these platelet defects is the same. So if you want to take the time and effort to know exactly what type, you have to resort to one of these sophisticated tests in order to diagnose. But using platelet count and mean platelet volume in a way can help you very much to categorize, and taking into consideration the clinical presentation, you can reach a reasonable diagnosis. These are the lists of all the platelet defect, and these are the genes. So you have to look through all these genes in order to know the defect, which is really very sophisticated. This is my favorite because it really summarizes all what I said. When you are faced with a mucocutaneous bleeding, we do first initial test to exclude the von Willebrand. Then we have one of two things, either normal platelet count or thrombocytopenia. If a normal platelet count, I do aggregation. If it is a normal aggregation, it is Scott syndrome. If it is an abnormal aggregation with these aggregation agent, it is these diseases. On the other side, if we get thrombocytopenia with low MPV, I have to think of this. If with high MPV, I have to think of this. If normal MPV, I have to think of this. Thank you very much. I know it's a tough topic, but I hope I simplified it for you.
Thank you very much, Professor Nevine Kassim, for your very comprehensive presentation.